Imagine a 7-year-old child who has just been battling severe chronic constipation for years.
Oh, that's incredibly tough.
It really is. I mean, the parents are completely at their wits' end. Pediatricians have prescribed, dietary changes, heavy fiber supplements, daily laxatives, but absolutely nothing works.
Right.
The child remains in absolute agony every single time that they go to the bathroom.
Yeah.
But what if the actual culprit isn't in their gastrointestinal tract at all?
hmm
What if the root cause of this systemic daily suffering is actually a hidden, highly destructive skin condition?
We constantly see this phenomenon where systemic compounding health issues are treated in isolation. Medical professionals, they tend to chase the most obvious symptom, like constipation, while completely missing a highly localized root cause.
Okay, let's unpack this. Welcome to the deep dive. Today's mission challenges a massive blind spot in how we categorize medical conditions. We are exploring a really surprising and vital question. Can children get lichen sclerosus, or LS for short?
Which is a great question.
Yeah, because usually when we think of long-term genital skin conditions, our brains automatically file them under adult problems, like specifically something that only affects postmenopausal women.
Exactly. That's the stereotype.
But to figure out if that assumption is actually leaving our most vulnerable populations suffering in silence, we've pulled together a stack of heavy-hitting sources for you today. We are diving into the 2018 British Association of Dermatologists guidelines, comprehensive patient information leaflets from major NHS trusts like Manchester, Lothian, and Addenbrooke's, along with the expert-curated Lichen Sclerosus guide.
Excellent sources.
So let's just tear off the Band-Aid right away. Do kids actually get this?
They absolutely do. Children of all ages develop LS.
Yeah.
I mean, dispelling the myth that this is exclusively an older person's disease is the very first hurdle.
Right.
Understanding how it presents in pediatric patients is crucial because, well, recognizing the early signs can literally save a child from years of profound physical discomfort and psychological distress.
Before we look at the physical toll it takes on these kids, though, we really need to understand the invisible battleground. We need to know what LS actually is at a microscopic level.
Yes, the cellular level is fascinating.
And the sources are incredibly definitive about what it is not. Like, it is not a fungal or bacterial infection. It is definitely not an allergy to a detergent or soap. And it is completely non-contagious.
Right, it is classified as a long-term, non-contagious inflammatory skin condition.
Hmm?
While the definitive root cause remains somewhat elusive in the broader medical community, the evidence strongly points to an autoimmune origin.
Okay, so the body is attacking itself.
Exactly. We frequently observe LS presenting alongside other known autoimmune disorders. You often see it in patients or, in the immediate family history of patients who have vitiligo, various thyroid dysfunctions, alopecia, or pernicious anemia.
I always visualize the autoimmune response in LS like a confused, overzealous guard dog.
I like that analogy.
You've hired this massive dog to protect your house from actual intruders like the viruses and bacteria of the world. But instead of watching the perimeter, the dog's internal threat detection system completely misfires, and it starts aggressively chewing up your own living room carpet.
That captures the essence of the dysfunction perfectly. If we examine that living room carpet, meaning the skin, we are dealing with the epidermis on the surface and the dermis directly beneath it.
Right, the top two layers.
Yeah. In a functioning immune system, the cellular turnover in these layers is perfectly balanced. But what's fascinating here is the specific mechanical breakdown when that guard dog attacks. Inflammatory cells, predominantly T cells, begin to migrate and cluster intensely at the exact boundary where the epidermis meets the dermis.
They aren't just physically occupying that space, though. They are actively launching chemical attacks, right?
They are. They're releasing signaling proteins called cytokines. And in this localized area, these cytokines completely hijack the skin's normal regenerative cycle. Yeah, they disrupt the basal cells, leading to a condition known as epidermal atrophy. The top layer of the skin literally thins out and loses its structural integrity.
Yeah.
Simultaneously, the underlying dermis undergoes changes that make it scarred, rigid, and inelastic.
I understand the systemic nature of an autoimmune disease, but I'm totally hung up on the localization. If the entire immune system is producing these misfiring T cells, Why are they deploying to such a highly specific, sensitive area of the body? Like, why target the genitals instead of uniformly attacking the skin all over the arms, legs, and torso?
The concept of tissue affinity is one of the more compelling mysteries we face. Certain populations of immune cells develop specific homing receptors that draw them to particular microenvironments.
So they're physically drawn there.
Exactly. However, it is vital to clarify that LS does not strictly limit itself to the genitals. Children can and do develop extragenital patches.
Really? Where else do they show up?
We see lesions presenting on the wrists, the upper trunk, the breasts, the neck, and occasionally the armpits.
Wait, a child can have an active LS patch on their wrist. Does it cause the same level of destruction as the genital patches?
Typically, no. Those extragenital patches might manifest as white, crinkly, paper-like spots, but they are overwhelmingly asymptomatic. They rarely itch or cause pain.
Oh, that's interesting.
Yeah, the genital environment is entirely different. It is subjected to constant moisture, occlusion from clothing, routine friction, and exposure to acidic bodily fluids.
Right, it's a much harsher environment.
Precisely. When the skin in that specific microenvironment loses its structural integrity and elasticity due to that epidermal atrophy, the physical reality for the patient shifts from a cosmetic oddity to a daily nightmare.
Yeah, if the skin is physically thinning and losing its ability to stretch, the day-to-day reality for a child just trying to navigate school, sports, and life must be staggering. The sources highlight that this physical reality looks wildly different depending on whether the patient is a girl or a boy.
It's a stark contrast.
Let's look at how this presents clinically, starting with girls.
The clinical presentation in girls is often what leads to the most severe delayed diagnoses, simply because the symptoms mimic so many other common childhood ailments.
The visual indicators described in the NHS leaflets are pretty stark. You're looking for white, shiny patches or sometimes intensely red or purple bruise-like areas.
And the pattern is very specific.
Yeah, it very frequently forms a distinct figure of 8 pattern that completely circles the vulva and the perianal region. Crucially, the sources emphasize that LS only affects the outer skin. It does not involve the internal vaginal mucosa.
Right, that's an important distinction.
But the outward symptoms are brutal. We are talking about pruritus, which is intense itching that completely derails sleep cycles. And then come the fissures.
Those fissures are the tipping point for the cascading lifestyle disruptions. When the atrophic skin splits, everyday childhood activities become intolerable. The friction from riding a bicycle or straddling a horse causes immediate trauma.
Ugh, that sounds awful.
It gets worse. More insidiously, routine bodily functions become a source of dread. Urine is naturally acidic, and when it washes over open fissures, the stinging pain is acute.
Which brings us directly back to the 7-year-old from our introduction. The severe constipation. I never would have instinctively linked chronic bowel issues to an autoimmune skin condition.
It is a textbook example of a psychological response to a physical trauma. The skin in the perianal region is severely inflamed, tight, and fissured. Passing a bowel movement physically tears the skin further.
Could they just hold it in?
Exactly. The child, seeking to avoid that acute pain, subconsciously withholds their stool. Over time, this withholding behavior leads to impaction and chronic severe constipation.
Here's where it gets really interesting, though. We just established that girls experience brutal perianal involvement with that figure of 8 pattern encompassing the anus. But the clinical data for boys indicates that perianal involvement is almost non-existent.
It's extremely rare in boys.
Why? Anatomically speaking, we are talking about mere millimeters of difference in the layout of a young child's pelvic floor. Why does the immune system aggressively attack the perianal region in females, but spare it in males?
That disparity highlights a significant gap in our current understanding. We observe the clinical outcome, but the specific biological mechanism driving it eludes us.
So we just don't know.
Not definitively. It could be related to subtle differences in the embryological origins of the perianal tissues in males versus females, or differences in the localized microbiome. Whatever the underlying mechanism, the clinical reality is that boys face an entirely different set of anatomical complications.
The most frequent presentation in boys is phimosis, which is an unusually tight foreskin that cannot be retracted. The British Association of Dermatologists guidelines cite studies showing that the incidence of LS in boys presenting with phimosis ranges anywhere from 12% to a staggering 100%.
It's a huge underlying factor.
That tells me almost every boy presenting with a tight foreskin could potentially be harboring an underlying case of LS. It affects the glands in over half of the cases and the meatus in about 37%.
The complications stemming from that metal involvement are deeply concerning. The scarring and rigidity can cause the foreskin to essentially trap debris, leading to the formation of preputial stones.
Like actual stones.
Yes, calcified masses beneath the skin. And in the most severe manifestations, the scarring can completely obstruct the meatus. If the urinary flow is blocked, the back pressure can ultimately lead to renal failure.
Renal failure triggered by a dermatological condition? That is a terrifying escalation.
It absolutely is.
But look at the societal trap here. If a young girl is chronically constipated, parents and pediatricians immediately pivot to diet and laxatives. If a young boy has a tight foreskin or is straining to pee, it's often dismissed as a normal developmental phase. How often are we treating the smoke while ignoring the fire simply because a physical examination of the skin isn't performed?
If we connect this to the bigger picture, it exposes a systemic flaw in diagnostic protocols. We are trained to treat the immediate complaint, but systemic issues require comprehensive physical evaluations. If a practitioner fails to examine the localized tissue, the root cause remains active and destructive.
Let's talk about how we actually extinguish that fire, because the sources are adamant that a gentle, observational wait-and-see approach is completely unacceptable when the tissue is actively destroying itself.
The standard of care mandates aggressive, targeted intervention. Across all major dermatological guidelines, the primary weapon against LS is the use of ultra-potent topical steroids.
Typically as ointments, right?
Yes, formulated as ointments to provide a thicker barrier.
Hold on. I am genuinely struggling with this protocol. I've read a fair amount about dermatology, and the universal warning with topical steroids, especially ultra-potent ones like clopidogrel, is that over prolonged use, they cause skin thinning.
That is the general warning, yes.
But you just explained that the cytokines from this autoimmune response are already causing profound epidermal atrophy. The skin is already paper-thin, rigid, and tearing. Aren't we essentially pouring gasoline on a fire by prescribing a medication globally known to cause the exact structural damage we are trying to prevent?
The hesitation you are expressing is precisely why so many parents abandon the treatment prematurely. It feels deeply counterintuitive to apply a known thinning agent to atrophic skin. But we have to look at the hierarchy of cellular destruction happening here.
Okay, break that down for me.
When you apply an ultra-potent steroid to healthy skin, yes, it will eventually cause atrophy. But the skin we are treating is not healthy. It is under a relentless active siege by inflammatory T cells.
So it's less about treating the skin itself and more about carpet bombing the immune response. It's like calling in a massive heavy-duty firefighting plane to drop fire retardant on a delicate ancient forest.
That's a good way to look at it.
You might hesitate to use something so aggressively destructive on those young trees. You might prefer the idea of just using a gentle garden hose. But a garden hose, meaning weak steroids or just regular emollients, won't do a thing to stop a raging crown fire.
Precisely. The ultra-potent steroid is the only mechanism capable of penetrating the dermis deeply enough to suppress those specific T cells. Once the T cells are forced to stand down, the cytokines stop disrupting the basal cells.
And the skin can heal.
Remarkably, yes.
Yeah.
Once the inflammation is halted, the epidermis can actually begin to regenerate and thicken back to its normal state. If a parent uses a weak steroid or stops the ultrapotent ointment too early because the outward redness faded, the fire simply continues to burn underground.
And what are the permanent consequences if that underground fire is allowed to smolder?
Chronic unmitigated inflammation leads to irreversible architectural changes and fusion. In girls, the labia minora can atrophy until they shrink and disappear entirely.
Wow.
The labia majora can fuse together, effectively burying the clitoris under scar tissue and severely narrowing the vaginal opening. We are not just talking about temporary itching. We are talking about preventing permanent, life-altering anatomical destruction. Proactive, aggressive treatment is non-negotiable.
The 2018 BAD guidelines lay out a very specific protocol for boys regarding this aggressive approach. They recommend a strict 1 to 3 month trial of these ultra-potent steroids applied once daily in tandem with heavy emollients.
Yes, that's the first line of defense.
If the phimosis doesn't yield to that steroid trial after 3 months, the guidelines dictate a referral to a pediatric urologist for circumcision. But the surgery doesn't just instantly cure the autoimmune disease, does it?
No, it removes the most severely affected tissue, but the underlying autoimmune tendency remains. If there are active lesions remaining on the glands post-circumcision, steroid therapy must absolutely continue.
Alongside the heavy pharmaceutical artillery, all the hospital leaflets heavily emphasize a complete overhaul of the child's lifestyle to protect that compromised skin barrier. It goes far beyond just applying a cream.
It requires hypervigilance from the parents.
Yeah, we're talking about banning all soaps and bubble baths, mandating soap substitutes, wearing exclusively loose, breathable cotton underwear, teaching the child to gently dab dry after passing urine so the acidic fluid doesn't linger on the skin, applying heavy barrier ointments before swimming in chlorinated pools. It's an entirely new daily routine.
That environmental management is critical. The compromised epidermis cannot defend itself against everyday chemical and physical irritants. The barrier ointments serve as a synthetic proxy for the skin's lost resilience.
Which brings us to the inevitable horizon. Childhood is temporary. These kids are growing up, their hormones are going to shift, their bodies will change. What actually happens to these children when they hit puberty and transition into adulthood? Is there a magical finish line where they outgrow this?
The clinical prognosis is nuanced and, frankly, highly variable. The data indicates that a significant portion of pediatric patients, specifically around 2 out of 3 girls, experience a substantial improvement in their symptoms around the onset of puberty.
2 out of 3 improving is a solid majority, but that still leaves a massive portion of these kids facing a different reality.
For that remaining third, the condition relentlessly persists into adulthood. Furthermore, even for those who experience that pubertal improvement, the disease often simply enters a dormant, quiet phase, only to flare up aggressively decades later.
Are there specific triggers for that?
The sources identify specific risk factors for this persistence. Obese children face a statistically higher risk of the disease continuing. Similarly, boys who have undergone prior surgical interventions in the genital area, such as a hypostadias repair, are at a much greater risk of persistent LS.
The NHS leaflets tackle the psychological anxiety of that persistence head-on. They explicitly state that if LS is proactively treated and well managed, it should not interfere with normal menstruation, sexual intercourse, or the physiological ability to conceive and bear children later in life.
Providing that definitive reassurance is paramount, but it is always delivered alongside a crucial caveat. Management of LS is a lifelong commitment. For adults living with long-standing chronic inflammation caused by LS, there is a recognized risk of developing squamous cell carcinoma.
Which is a type of genital skin cancer.
Correct.
The guidelines note that malignancy hasn't been reported in pediatric girls, but the risk slowly emerges in adulthood after years of that cellular disruption. That necessitates regular, long-term clinical follow-ups, often annually, even if the patient feels completely fine and the disease appears stable.
Yearly checks are a must.
I keep thinking about the psychological weight of that conversation. You are sitting down with a teenager and telling them, you have an incurable autoimmune condition. It might vanish in a year, or it might stalk you for the rest of your life, require daily maintenance, and slightly elevate your risk for cancer. How do practitioners balance offering hope with enforcing the strict reality of lifelong surveillance?
This raises an important question about patient autonomy and how we frame chronic illness. The goal is to shift the narrative away from existential dread and toward empowerment.
Making them feel in control.
Exactly. The psychological burden thrives on uncertainty. If a young adult understands the mechanics of their condition, if they know that vigilant maintenance directly preserves their anatomy and their reproductive future, it neutralizes the terror.
That makes total sense.
It transforms a terrifying medical unknown into a highly predictable maintenance schedule. You utilize your ointments, you modify your lifestyle, you attend your annual screening. The vigilance becomes an act of routine self-care rather than a reaction to panic.
So, what does this all mean? If we synthesize the dermatological guidelines, the hospital protocols, and the expert consensus, the core truth is undeniable. Children absolutely get lichen sclerosus. The ultimate tragedy of this disease isn't just the cellular damage. It's the fact that it masquerades so convincingly as everyday childhood complaints.
It hides in plain sight.
Yeah.
Yeah.
A stubbornly tight foreskin is written off as a developmental quirk. Chronic, agonizing constipation is blamed on a lack of vegetables, and all the while, an autoimmune fire is quietly destroying their tissue.
And ignoring that fire guarantees permanent architectural damage. The only effective countermeasure is early detection, the aggressive deployment of ultra-potent topical steroids, and a steadfast commitment to lifelong surveillance.
For you listening to this, whether you are navigating parenthood, you are a concerned aunt or uncle, or you are simply a relentless learner who values being well-informed, internalizing these facts is how we dismantle the stigma surrounding pediatric genital conditions.
Absolutely. Stigma is the enemy of treatment.
When we refuse to talk about these areas of the body, children suffer in the dark. Just possessing the knowledge that a child's sudden severe bathroom avoidance might actually be rooted in a dermatological condition, that single insight could literally save a child you know from years of silent, excruciating suffering.
It underscores exactly why we must continually challenge our initial assumptions and look beyond the obvious symptoms in healthcare.
But before we wrap up today's deep dive, there is one particular detail buried in the sources that I have not been able to shake. The guidelines note that simple mechanical friction, like the rubbing of tight clothing or the pressure from a bicycle seat, can actually trigger or violently exacerbate the autoimmune response in the skin.
The Koebner phenomenon.
Yeah.
It is a fascinating mechanism where physical trauma to the epidermis essentially acts as a beacon, drawing the systemic immune response to that specific localized area.
So I want to leave you with this puzzle to mull over. If a complex, highly destructive autoimmune condition can lie completely dormant within our genetics, just waiting for something as mundane as physical environmental friction to wake it up, what other types of invisible friction in our modern world might be quietly interacting with our genetics right now?
That's a profound thought.
Whether it's chemical exposure, dietary changes, or environmental stress, what else is out there just waiting for the exact right moment to pull the trigger on our immune systems?
The interplay between our genetics and our environment is the next great frontier in immunology.
Something to think about the next time you throw on a tight pair of jeans. Thanks for taking the deep dive with us.